There's the ding. That means we sing. I'm told that I get to introduce myself, which is very dangerous because I'm really tempted to say I'm the backup point guard for the New York Knicks. I will not say that. I'm Dr. John LaPook, so I am the chief medical correspondent for CBS News. I do 60 Minutes, Sunday morning, evening news, morning, not much going on at CBS, so I'll just move to my other job, which is I'm the chief medical correspondent. I'm the professor of medicine at NYU Langone Health. I do internal medicine and GI. I'm kind of a dinosaur. I graduated medical school when dinosaurs roamed the earth. So, and actually I do more internal medicine than GI, which is unusual. And then the last thing is I started something I was at Columbia for 37 years. 2013, came over to NYU Langone Health to start the Empathy Project, which is we use Hollywood quality short films and other materials to teach clinicians in training and others to be more empathic and sensitive and competent. You can actually do that. And to empower patients to demand that. It's now 13 years later. Maura Minsky, our director, is here. I do urge you to go see her afterwards. Our website is empathyproject.com. We have a Center for Empathy and Medicine. And so this is very much right up and down my alley, both as an internist and as somebody who's been studying empathy. I think Aspen Ideas Health did a gorgeous job assembling this because you're going to see the perspectives are global, national, and then in the trenches, in the middle, in the trenches. So I'm going to start off just with they're going to each introduce themselves and tell you sort of what their filter and how they define patient-centered care, because in my research, we've already met online, and then I've done some more research, and like everybody defines it a little differently. I will tell you a little anecdote, which is the guy calls the doctor's office because he's been having some chest pain, and now and then, and he's told, well, you can have an appointment in 6 weeks. And he says, I could be dead by then. And the receptionist says, well, then be sure to have somebody call to cancel. Oh. So, of course, tongue in cheek, but it really does highlight, what's the system for? Is it for the office? Whose convenience? Who's really at the center? Mm-hmm. So I'm going to start off with everybody identifying themselves. I'm going to start with Nikayla. Everybody will say their name, where they are, what their focus is, and sort of what your definition of patient-centered care is.
Great. Well, I'm Nikayla Cook, and I'm the executive director at the Patient-Centered Outcomes Research Institute, or PCORI. And I may just start by asking you if you or a loved one has ever had to make a decision about your health or health care, or even face a dilemma in a clinical setting where you felt you didn't have the information that you needed in order to make that decision.
And pretty much every hand goes up.
And that's really what PCORI and I do on a regular basis, is try to think about the evidence and the information that's needed that we can get into the hands of patients as well as other decision makers so they can make a choice that's right for them in the healthcare setting, and really take into account different preferences, different circumstances, and those needs. So when we think about patient-centeredness and what that means, we really can't do that work without engaging patients as well as their family members and caregivers to really understand what's important to them, what matters to them, what questions they're facing in the clinical arena. And we take that information and work together in partnership with patients, caregivers, and families in order to really think about the research question, how the studies are going to be conducted, even how the information that's generated from those studies is disseminated back to those patients as well as to broader populations implemented in clinical practice and in healthcare. So to me, when we talk about patient-centeredness, it's about centering around an individual's system of health and thinking about what that system of health means for that individual and making sure we're taking into account all of those issues. And we need to do that by making sure we're partnering, co-designing, as well as implementing together. I would also just say that I come to this work and I come to PCORI because PCORI actually just embodies a lot of what I'm so passionate about, which is that we have to have people at the table if we're actually going to be able to make a difference in the health outcomes that matter most to them. So that's generally the way I would think about patient-centered.
And Ishani?
Yes, I love that answer. I am Ishani Ganguly. I'm an associate professor at Harvard Medical School, a former healthcare journalist, and in my current role, I study primary care and healthcare delivery and payment. I teach students and residents. I am a practicing general internist, and I also do some work in policy in DC. And my answer to this question, I would build on yours, is to say that patient-centered care to me is timely, accessible, affordable, and high-value care that is really centered around and grounded in a strong primary care relationship. And what I mean by primary care is the 4 C's some of you may have heard about. This idea that your primary care doctor or team is the first contact or first place you can go to when you have any kind of a question or problem, that there's a continuous trusted relationship. You've known your team for years. There's trust built in. It's comprehensive care, meaning they're thinking not just of one organ, but thinking of you holistically as one person and thinking about your care and providing a range of services that they can do in that office before sending you out. And finally, the idea of coordination of care, that your primary care team is helping you navigate care across different settings, across different doctors you may be seeing. And we can talk more about how to build that up, but I think that is so central to care, and we have lost some aspects of that, and I want to think about what we can do to make that better.
Great. And then, so this is the 50,000 feet above. We're going to, after Michael tells you about himself, we're going to go a little lower, and then we're going to get into it sort of back and forth, have a lively discussion.
Mm-hmm. Yeah, I'm Michael Howell. I'm Google's Chief Health Officer, which sort of sounds like a made-up job, best job in the world, and maybe is.
But you can Google it, and it actually exists.
Our team's job is to sort of look after all the health work at Google. 22 years or something before that, also starting in the last century, I trained or practiced as a doc, also an internist, pulmonary and critical care. And one of the lenses that I come to this through is 10 years of work on humanizing critical care. And one of the things that we did early in that work was to talk with patients and families a whole bunch about what was the right word. And patient implies a doctor. Much of health, right, it has to be in a dyadic relationship. Much of health comes from individual actions without a doctor involved. And so we named that effort at the Beth Israel Deaconess Medical Center, right, home of Open Notes, first patient bill of rights in the country. We named it person-centered critical care for a reason for that. So I think about people, and now that I'm at Google, where people come and ask us questions about their health all the time, I really see that. I'll tell one quick story about what it means in actual care. Had a guy come in, I was working overnight, older guy on dialysis, gram-negative, septic shock, in the ICU. And you're like, what are you hoping to get out of this? And he's like, my granddaughter graduates from high school tomorrow at noon. I'm hanging around to see that. And here he is with E. coli in the blood. And so we resuscitated him enough to get him out to go to the graduation. As the person responsible for quality in the ICU, boy, I dinged a bunch of quality measures for that. But it was the right care for him, right? And so my frame for this is best health for everyone, everywhere, on their own terms.
I love that so much. So it's the computer guy who is thinking about people and the soft side of it, and maybe things, you're in the ICU, you're thinking about what are the ventilator settings at, what's the blood gas, and you're thinking about getting this person to an event.
It's a life. I mean, the only sad part of my job is I don't take care of patients directly now, and everyone in the ICU, it is a life-changing moment for them. It's a privilege.
You're reminding me, years ago here, there was a woman who was a world-class violinist, and she ended up in the ICU. And what drove her crazy was the sounds of the ICU. Yeah. And she ended up composing music that sort of interdigitated with it, that brought it all down and made it livable. I was like, that is chef's kiss, right? That was so brilliant, and thinking out of the box, thinking out of the defibrillator. I'm going to go across and ask each one of you to sort of like bring it down into stuff you've actually done to give everybody else sort of an amuse-bouche of what you've done. And I'm wondering, in the last 10 years, what patient-centered research that you've done has really made a difference, and what's something that's just been so stubborn and you can't get your arms around it?
I love that question. And, one of the things I would say about the work that we've done is that there's been an increasing and growing recognition of the importance of patient-centered approaches to research. And that influence we're starting to see more broadly. And really, I think PCORI has had the fortune of leading the way in some of that and really understanding what it means to engage with patients very deeply in order to understand the questions that are important, to ask those questions, the outcomes that matter, and how the work is done. I'll give you an example from a study related to asthma, and we know that millions of Americans suffer with asthma in this country, and that especially if you have severe asthma, how you treat that and how you prevent exacerbations, and the fact that people actually need different things in the way that they approach their asthma care. And we were told this by patients, and the study that we funded actually looked at usual care of taking an inhaled corticosteroid on a daily basis, which can be quite challenging for some patients, or actually adding that inhaled corticosteroid at the time that a patient is having an exacerbation or needing to have a relief nebulizer or inhaler. And we actually found that what mattered to patients was the number of days they missed from work or school, their quality of life, their productivity, where clinicians really cared quite a bit about, did it reduce hospitalizations, did it make your symptoms better, et cetera. And so all of those outcomes were incorporated in the study, and we actually found that that inhaled corticosteroid at the time of relief nebulizer or relief inhaler did improve symptoms. It also reduced the number of days missed from work or school. And the patients that were involved in that study actually felt that we answered the question they needed to know about how to manage their asthma. So that's real progress in terms of thinking about things. Things that have been incredibly stubborn is that we recognize it's very difficult to do the level of engagement that really works in research. And we've had to come up with a number of ways to build capacity for patients and caregivers and family members and communities to be true co-participants in research. And we've also had to come up with a number of ways to help the academicians, the researchers, to understand how to be communicative, how to not think about patients as just participants in research, but really partners that share power in how a study's designed, the outcomes that are important, as well as how it's really disseminated and implemented. And maybe one last thing I'll say that's been really a big challenge is that this is about redesigning research, doing it differently. Research done differently is actually something that requires culture change. It requires institutional changes. And those things are stubborn and challenging, but we're going to keep, chipping away at it because we've actually seen the benefit and know it can be done. And for those that have done this work with us, they tell us we can't see doing it any other way. So we're trying to make this approach very central, not tangential, what you do from the beginning, and the only way that it's done.
When you talk about things that are stubborn, have you had pushback on including social determinants of health into that? I think about your asthma research. Last night I was at a dinner, and Joe Allen, who heads up the Healthy Buildings program at Harvard, told us that 90% of your life is spent indoors. 90% of the air pollution that you breathe indoors. And I wonder if things like air filters, which can take out the particulates, could dramatically decrease asthma. I remember when the wildfires happened, they came down. I happened to have one in my kitchen. It's supposed to be under 5. It went to 60 or something like that. I just turned it up and it went down to under 5. And had there been somebody with asthma, actually my wife had some allergy. That she was the canary in the coal mine. Before I looked at the machine, I said, wow, it's 60. And then she felt better after doing that. I wonder, are you including things like that?
We definitely are. And one of the things that we actually have, I think, really focused on is the fact that when we talk about a system of health for an individual, and we start to understand what matters to them, as well as the preferences and the needs that need to be met, that is that we have to be able to really move what we're trying to do to where the patient or the person is, as opposed to imposing it. And often that means that there are other things that we have to think about to address. And if we talk to many of the investigators that are involved in these types of studies, they'll tell us that's where the relationship starts, is when you actually start to listen to the other things that are going to be important and not the ones you thought are most important and brought to the table, and that we have to address those in order to be able to move forward. So a lot of the studies that we fund at PCORI do take into account what I would call this kind of multi-component approach to interventions that are addressing both the clinical factors as well as those factors that are driving clinical outcomes that may not necessarily be identified as clinical factors.
That's the perfect leader into Ashani's question, because you talk about things that are not intuitively obvious, maybe to think are so important. I so admire your research, because you're going deep on something that I think most people, I don't know, we kind of know it's there, but it's, so the question is, how do the way doctors are paid help or hinder patient-centered care?
I'm going to save that for later, actually, John. I'm going to talk about a measure that actually addresses what you're talking about, if that's okay.
Perfect.
So we've been thinking a lot about the burdens we place on patients in the healthcare system. And we ask patients to come in for a blood test or an MRI, and we don't often think through what that means for people who are taking a couple of buses to get to our office just to discuss a lab result, for example. And so there have been older studies looking at the time burdens, measuring that even for an office visit, the average time is 2 hours, which might be maybe 20 minutes with the actual doctor, and there are large disparities in this cost burden based on things like race and income. And so we've developed this measure called Healthcare Contact Days, which uses national billing data to measure the days that we ask patients to come in for anything from a blood test to being hospitalized. And it turns out from our work on this that the days are really common, that most of them are happening in the ambulatory setting. So it's when patients are coming in for office visits, blood tests, et cetera. The average older adult spends about 3 weeks or 21 days a year. 11% spend 50 days or more in a year. And when we look at patients who have metastatic cancer or patients with dementia, those numbers go up quite a bit, to the point that a large share of their remaining days, in many cases, are spent accessing care outside of the home. We find that there's really diminishing returns on these contact days in terms of patient satisfaction and their ease with managing their care. That goes down as contact days go up. And so we really seeing this clear signal also that there's real missed opportunities to make better use of those days. And so, for example, it's very rare in the Medicare population, for example, that 2 office visits are scheduled on the same day, which would be convenient for patients, but just doesn't happen. These contact days are less often on Fridays. Doctors are taking Friday. I'm probably one of those doctors, but we're taking Fridays off, and maybe that's something that patients would want to have that option. And so we are studying this not because we want to figure out what is the right number of contact days. There's no magic number. But my hope with this measure, and as we're using it more and more, is to talk about it at a couple different levels, right? In the exam room, when I'm talking to a patient about which osteoporosis treatment they want, we want to think about the contact days involved in administering the treatment, in any safety labs they have to do, in the follow-up office visits, and how well their disease is managed. We want to be using this measure, this concept, in the C-suites of health systems who are designing care, right, to maybe co-locate dementia care all in one day or setting for a patient, so they don't have to run around to many different places to get their care. And we want to think about this in DC as we're designing policies like bundled payments, for example, that sort of emphasize and make it easier to coordinate care. And finally, in research, and that's where this aligns really well, we want to be thinking about this as a measure alongside many other measures of patient care experience and quality, thinking about the time burdens of care alongside those.
What is that term? Is low quality?
Low value care?
Low value care. Can you just touch on that?
Sure, yeah. So thank you, John. So as I think about contact days and what could help with contact days, I think about 3 buckets. The first is to reduce low value care. And what I mean by that is tests and treatments that have little to no benefit and can cause harm, and yet are rampant in the health system. One example is an MRI for low back pain that doesn't have any red flag symptoms, where the information wouldn't help you. There are many other examples. And so the first idea is don't do the unnecessary care, because that care can also cascade into more stuff downstream. The second bucket is to consolidate and organize care better. So you're doing those 2 visits in one day. You're getting the blood test at the same time you're coming in for a visit. Patient comes in for knee pain. They're due for their B12 shot. You get them both that day. The third idea, to the extent that there's extra burden in getting care outside the home, is to shift care to patients, right? To do telemedicine when that's appropriate, to invest more in home-based care.
Got it. Michael,
Yeah.
I guess a little poll before we start this. Christian Archer from Gallup is in the audience. He's wearing the empathy hat over there. Raise your hand. Hot off the presses, he told me, thinking about your most recent care experience, to what extent did the medical profession listen to and understand your explanation of your health or condition? Completely, 36%, mostly 41%, only partially 15%, not at all 7%. Okay, so with that as a context comes my question. How many people in the audience have used AI to answer a medical question? Every single person, okay. Here's my question to you. Obviously, you've looked at this. How does it affect what happens subsequently in the caregiver, I'm always careful not to just say doctor, in the caregiver-clinician-patient relationship?
Yeah, it's something we think a lot about, right? That if we take, what do we know from the literature before AI? Anybody know the study in Sweden about what does it do to your mortality if one of your family member becomes a doctor? Yeah. It's an amazing study, right? So in Sweden, for a while, they had this lottery. So there's some randomization. And then some people got into medical school and some people didn't. And then it turns out if you had a family member go into medicine, you live longer. And people are like, oh, it's just because you get more money.
Unless you go broke paying for medical school, that's why in Sweden, right, it's less expensive.
It could be, but right, this is the best study that I know of. And you're like, oh, it's just because they get more money. So how would you control for that? Well, they looked at people who went into law school. Mm-hmm. And the mortality benefit of getting a doctor in the family is actually, on par with treating high cholesterol or blood. I mean, it is amazing.
Believe it.
And it's not because the family members treat them like doctors. The thesis, right, it's a guess, but the thesis is they act like coaches. They give you, we talked at another panel, anybody gone into healthcare and been blown off? Okay. What I do for my family is I help them with the secret code words to make the doctors pay attention. Do you do that? Mm-hmm. Yeah, right?
I do.
Because they're secret code, not code word, right? But they're like words where people are like,
Crushing chest pain going down my left arm.
Yeah. Worst headache of your life.
Yes.
I'm really worried that I might die, and my family member, who is a lawyer, right? So now we have some evidence that access to expertise, not providing care, makes you live longer. The great promise of AI is doing that for 8 billion people, right? Mm-hmm. So we do a whole bunch of work on how do we assess the safety and quality and make it better and better and better over time. It's complicated. It depends on where you live, right? So if somebody's like, oh, you should take Tylenol for that, that is a terrible answer in London, right? What is the most common, I'm a pulmonologist, I really appreciated all the pulmonary things. What's the most common cause of coughing up blood? Depends on where you live. Right? So there's a whole bunch of nuance to that. We are starting to see some third-party work that we're not involved with show, really improving quality here. And so the hope is, I think we would all agree, I hope we would all agree, that the evidence is overwhelming, that informed, engaged patients who understand their care and have agency in their care have much better outcomes. Mm-hmm. And so thinking of this as a tool for that, we have experiments in the field right now on helping people prepare for a doctor visit. Turns out a coach is good for that, right? It's what I do with my family. I just want that for 8 billion people. Now, what does that mean for the doctor-patient relationship? Well, again, we sort of started this with the doctor-patient relationship is a dyadic relationship. What we're starting to see is some ethicists write about it evolving to a triadic relationship. That's a really interesting moment. I'm not an ethicist, but I'm glad smart people are thinking about it. And so the important part is that what we need is evidence about where AI works and where it doesn't in health. And then we should use it where it works and not use it where it doesn't.
My follow-on to that
Yeah.
is, I suspect you're aware that there's been some recent replicable data showing that if AI is pretty good at making diagnoses.
Yeah.
If you add on a doctor, the doctor degrades the accuracy of it. So that was surprising, and it was replicable and interesting. So it raises the question, when you think about this triad, who's good at what? So the AI may actually be better at making that diagnosis and saying, and especially if you have ambient listening and now you've got large language processing and it says, oh, the guy said he was from Mystic, Connecticut, that's near Lyme, and they're talking about the pain in his knee, and picking up on that. But what it doesn't have is hairs on the back of its neck that can stand up, that whatever that intuition is that we have, every clinician I think has had that moment. I don't know why the hairs are standing up on the back of my neck, but they are. Happened to me a couple of months ago when a woman who came back from a vacation in Indonesia, she was talking about her snorkeling. She suddenly said, I have a headache. She said, headache, and you get a couple of Tylenol. I called an ambulance. Don't ask me why. She had a normal neuro exam. 15 minutes later, she couldn't move her left side. I canceled my patients. We went to the emergency room. She had a huge bleed.
Yeah.
She just went home 2 months later. I've been asked by the head of rehab, neuro, and neurosurgery why I made that decision. I have no idea.
Yeah. No, I have one of those of college student comes into the ER, febrile like 104, bad headache. You're like, okay, we're gonna LP, like whatever. And like for some reason, while I sent off the LP, I gave her meningitic doses of ceftriaxone. LP comes back 0 white cells, which normally like rules out. And I was like, okay, great, you can go home. Like probably flu, like whatever. It was a long time ago. 36 hours later, blood cultures come back with Neisseria meningitis in the blood, right? You don't know what that is.
If you have enough time, we'll tell you about all the things we've missed.
But
the reason why I'm using that is that the end of that story was going to be, I know her for 40 years, 38 years. I took care of her parents, may they rest in peace. I take care of her daughter. Yeah. So there was this longitudinal, whatever it is that happens when you get to know somebody, that goes in there. How well can computers get to know somebody?
Yeah. So I think the most important paper written that everybody should read is Zach Cohen's paper, Compared with What, about compared to what we have. So most people in the world don't have a doctor, and 40%, I think is now the number, right, of Americans don't have a primary care doctor. So solving that solves only a small slice of the health problem. But then let's talk about how do we know where it works. So our team has published like somewhere north now of 300 scientific papers about health and AI, right, in JAMA, Nature, like all these journals. And so one of the things when the technical architecture for modern AI was invented at Google, like 275 yards from my desk, the transformer, the T in GPT. And we started like thinking about this a while ago. And one of the things we thought was, how do we tell these things? So we started building this series of how do we do safe testing harnesses over time. So first we're like, well, can it pass the equivalent of a licensing exam? Great. It was like a miracle in 2023, and now it's just like routine. Then we're like, well, okay, what's next?
The Turing test. Can it seem to be human?
Next for us was, how do we evaluate residents and medical students? And so we have this thing called the OSCE, the Objective Structured Clinical Exam, where we have standardized patients, right? Of like they learn the script for lupus or breast cancer. We send in the resident or medical student, and they do history and physical, and they get graded by the expert who's watching by video, and they get graded by the patient on empathy, rapport, and connection. So we hired a bunch of standardized patients. We randomized them to do an OSCE by text with a bot or a board-certified general internist or a family practice doc. Bot 1 on diagnosis. And the patient graded it higher in empathy, rapport, and connection, which is shocking and very upsetting. And then we did a safety study with one of the Harvard hospitals on real patients, but a primary care doctor going in by, Zoom or Meet or whatever, Teams, I don't know which one, and like ready to take over. We didn't have to stop any of them. And now we have a randomized control trial in the field. So the answer to your question of 5,000 patients looking for urgent care by telemedicine is the study. One of the really interesting things from the safety study was patients trusted the bot because it talked with the doctor, not because they trusted the AI. They trusted the doctor, and then therefore they trusted the AI. And they would say things like, wow, this thing really listens to me and lets me tell my story, and then condenses it for my doctor.
Yeah.
Because it has time for it. So the answer to your question of will it have that intuition, will it get to know people, is an empirical question that we're trying to be on the march to answer. I have thought it was going to fail at many of these gates, and it has not. I do think the data of bot alone versus bot with doctor versus doctor, I do think that data is nuanced.
Yeah.
That some of the studies about the doctor makes it worse don't simulate real world care.
Okay, and I know you may know about the Reddit study, where they said that the bot was more empathic than physicians, was against physicians, and when they drilled down on it, it was because they gave longer answers, and they would say, oh my God, I really was, thinking about it, and it was sort of, and you're going to Costa Rica on this trip. Oh, it's beautiful this time of year, and you should visit that. Okay, fine. I want to spend the last 10 minutes before we have Q&A on. We'll just go around. 5 years from now, what does a good patient visit look like practically and mechanically compared to today? And we'll just go across and then have at it. I'm going to sit on the side and you guys talk amongst yourselves.
I may say that I really look forward to the day when a patient shows up informed, able to be a partner in health in a way that they actually can articulate, what the issue is and the dilemma is, have choices for them. And if the answers are not known, that they actually are then included in the ability to have a randomized trial, study design, something of that nature that actually helps us to know this is an unanswered clinical dilemma, that we need to understand the evidence behind it in order to provide information to patients to be able to actually inform them for what they would do next. And that cycle of being able to show up, know whether or not that dilemma is already, results are there for them or they don't have the information, triggers something that is a learning cycle for health that basically then says, if we don't have the answer, we're going to figure it out, and that we can do it more rapidly because of the data systems, the structure of that information in healthcare, as well as the ability to have a patient with some degree of ownership of their data that allows them to be able to delve into that in a way that the next time another patient comes, that information's available. I also want to make sure that when that encounter is over, that we're thinking about not just the unanswered question, but how that information that an individual patient may have had or not had gets to others, and that we're able to think about the way in which it's disseminated, the way in which it's implemented, and that the research behind that is actually strong enough to help us know the strategies that work. So we have to do research in real-world settings. We have to bring an integration of both practice and clinical care with the needs of what patients and families and caregivers really need. And I think that's something that we're moving toward, but there's a lot that we can do, especially with the opportunities that exist today to be able to make that cycle real.
Bless you.
Well, that was just a little, beautiful little sneezelet.
I thought that was a question for
I can't raise it to a sneeze. It was a sneezelet. It was beautiful.
So as you asked that question, I was thinking about a patient I saw a couple weeks ago. And I'll tell you about the visit, but I think even the notion of it happening in the context of a visit should be expanded to everything that happens in between. So this is a patient I've known for years. She works in healthcare, and so we've talked about it, and she herself has said, I get nervous with little symptoms because I have seen the worst of things. And And that is where my mind goes. She comes to me for a physical. We talk about her kids. We talk about all the different, preventive services or preventive care that I want to offer. We are checking her lipoprotein A, many other things. She also mentions that she's had this weird episode a few weeks ago where she had this buzzing sensation and some numbness. And we talk about what that could mean, and we say we're going to watch it really closely, and we come up with a plan. We say this happened once, let's keep watching, do a little bit more of a test of time. Week later, she messages me, because we all are messaging our doctors, right? That's another form of the way that we now engage in care, and tells me it's come back. And we decide by email that this is going to be, the next step is a brain and spine MRI. We're concerned about multiple sclerosis. The story isn't over yet, so I don't have a conclusion. But to me, exemplifies a couple of things. And I should have mentioned she had used AI to think about those symptoms and think that she needed to bring them to me. And she was concerned about those things. So in the visit, I was asking, what are you worried about? We thought through the differential, and we had a plan. So I think it's spending that time to understand where patients are coming from, where their information is coming from, and making sure I'm addressing, are you concerned what the symptom is? Is it that the symptom is bothering you? Do you want the symptom to go away? What combination of things are really your goals? And we had a plan. It wasn't just, let's, talk to me later if it comes up. We know what the steps B, C, and D are. And then there's also the piece of just having that wraparound communication. It doesn't have, not everything has to be an office visit. I'm a pretty part-time doc, so office visits are hard to come by. I'm one of those people, but then I am available all the time for my patients through messaging and things like that. I do think we need better payment models to organize care so that this is possible for patients to be able to do this with their doctors. But that's what I think about.
Got it.
Care today is cold, impersonal, fragmented, filled with waiting.
Mm-hmm. Well, it is called a waiting room.
We say,
yeah.
We changed that term. We have changed the term.
And part of the result of that is that your chance of getting the evidence-based stuff, once you see a doctor, is 60%. And also, we have a bunch of diseases that have no treatment or cure. Okay, so what do we see 10 years from now? We haven't talked about it, but on the basic science side, we're seeing these amazing leaps forward. And I think we've all practiced long enough that we've seen these things that are miracles, right? Like HIV, Hep C, childhood leukemia, right? And so I think that one thing is we'll see the shortening of time between true breakthroughs, which should be amazing. Then on the care side, I think we know what we want it to look like, right? We want to have all of our own health data when we want it without special effort, and then be able to share it and control it with who we share it with. That we want to get care when, where, and how we want it. Mm-hmm. Person-centered care by definition doesn't care where you are. We want patients and people, family members and caregivers, and doctors to be supported by AI so they understand and can take evidence-based actions. And that the result of that should be better life, longer quality, and better care, right? And which parts of those are done by people and which parts are done by technology, there used to be a series of commercials. Anybody see Esurance commercials? So they had this tagline, which I think is trademarked, or I would totally steal it, of technology when you want it, people when you don't. Okay, right? I lived in the south side of Chicago for a while, like world's best pizza, like I don't care, New York. And sometimes I would order from Domino's because I could do it in the app and I didn't have to talk to somebody. Be very different if healthcare were like that, right? That you could choose.
Often people want both people and technology.
Yeah, people when you want technology when you don't.
At different times.
Maybe
right?
at the same time.
So we should. My hope is that we'll be able to support what the patient wants and needs, so that they have the best health outcomes.
I mean, to me, technology at the same moment as the person is, the patient sitting across from me. I'm talking, and it's picking up on something that I don't realize. And the example I would use is a few years ago, this woman who I've known for 30 years came into my office and she said, "Hi." And I said, "What's the matter?" And she burst into tears. Her whole life was falling apart. And when she stopped crying, she said, how'd you know? I said, it was too big of a high. And, after I finished patting myself on the back, I got like, oh my God, what have I missed? That just was so obvious. And I think about technology, if you have ambient or some AI system that's listening, it may be able to pick up on something that's not intuitively obvious. Not just on the medical side, which is some sort of, fancy schmancy diagnosis, but tone of voice, based on I look at the left, based on the tone of voice in the last 10 encounters, you might start inquiring about maybe there's some anxiety. Maybe with video it can look at body language. Anyway, we're doing some research in the Center for Empathy in Medicine, and we're lucky enough to have our Frankfurt family director of the Center for Empathy in Medicine. She's the Frankfurt director of the Center for Empathy in Medicine. Jen Adams, who's in the back. So if you're interested in that subject, talk to her. And perfect, at 10 minutes left, we're going to open it up for questions. So who's got a question? And when you do get the mic, eat it. Like really. That was just, exaggerating for dramatic effect, but it's really hard. So how about first person in the white sweater? And I'm sorry I'm describing you so just impersonally.
Okay. No problem. I'm Taylor West. I lead Healing Advocacy, which is a policy organization that's helped build the regulated psilocybin therapy programs in Oregon and Colorado. And we've been able to build these in a very patient and people-centered way, in part because a lot of the interests that push against that have not been at the table, right? We don't have insurance companies, we don't have a pharmaceutical company, we don't have those pressures. But now we are turning our focus toward the likelihood that FDA is going to approve one or more psychedelic-assisted therapies in the next year, probably, and trying to think about how we can leverage or press on policy, regulatory environments, healthcare providers to shape that care to stay as patient-centered as possible, despite the fact that now we will have some of these confounding factors at the table. And so I'm really curious about what, in your perspective, are the best levers. Where can we influence the way a new care model gets rolled out proactively before sort of standards get set into our kind of more typical healthcare systems?
Nikayla,
Yes,
I think that's up your alley.
I'd love to speak to that because, one of the things that we haven't spent as much talking about is really what we call engagement at PCORI, and it's meaningful engagement, meaning that we're thinking about all of the different players in the healthcare ecosystem and what kinds of decisions they need to make, what are the types of things they take into account, and doing that very early on. Because I've mentioned a lot about patients and caregivers and families, but we also think about that type of engagement for policymakers, for purchasers, for payers, because sometimes we'll see very aligned philosophies, ideologies, et cetera. Sometimes they're very disparate. And we often will take an approach of trying to make sure we're understanding what's important, finding the shared interest, and then working together. And it may take us to take siloed engagement opportunities first and then bringing the cross-cutting approaches. But often doing that early on is part of the way that we actually work through the challenges together and get to the outcomes that we think we're really trying to influence in a way that's very patient-centered. The last thing I'll just say is that we see this in a number of situations where, for example, with one of the studies that we funded at PCORI, which was really focused on blood pressure monitoring, and we know that, half the people in this country have hypertension, but only a quarter of them are really controlled. And one of the things that was really important was to think about what is it that's most convenient for patients, even if the care delivery model didn't work for that. And there was a remote monitoring arm in this study that incorporated additionally essentially pharmacists as well as other nurse practitioners and extenders of healthcare to make decisions in escalating medicine versus the traditional care of coming into the clinic. That kind of evidence was necessary in order to now move it into implementation and practice by having all of those at the table, that now health systems across 18 different health systems, 200,000 patients, as well as over 1,800 different care sites are involved in implementing that evidence. And the convenience of patients was part of what drove that. But it was the engagement of all the players that allows it to happen.
Next question, woman with the denim jacket and the winning smile.
Hi, Priscilla Vanderveer. I'm the executive director of an org called No Patient Left Behind. And I'm going to ask this question, but I don't want it to be confrontational, because I think all of your sentiment, all of your projects, all of the amazing work you're doing is critically important.
I want to make sure, because often the questions are
It's
a
short.
lot of this and then a short thing. So just
It's very
I want to
short.
give enough people their
Is
5 minutes.
when you have a conversation like this, but there isn't a patient on the panel. And again, it's not to diminish the amazing work that all of you are doing, but I think sometimes at events like this where that happens, I'm just very curious about your point of view on that.
Yeah.
It's a great point.
I take it as a great point as well. And one of the things that we really strive to do is to not also always just have a one patient feeling like they have to represent all patients. And so that point of view is so important. And I also want to recognize that we hear that quite a bit from the communities that we engage with. And we do take a very intentional approach to making sure that when we are talking about anything, that we're thinking about not the patient just as a representative here, but also in the what is it we're talking about? How are we co-designing it? And how is it going to be rolled out? And so I think just wanted to amplify that point, that is an important consideration.
Person in the back with the blazer.
Yes, so thank you so much for a great presentation. Janusz Kaleta, New York City. And my research is actually in personomics, which is knowing the patient as a person. And, as we're witnessing the shift, in medicine, into precision medicine, we often, leave the omics, which is personomics, and which is really knowing the patient as a person. We often talk about patient, but we do not really consider that person did not leave the personhood outside of the clinic or outside of the hospital. When I was dealing with persons during the COVID-19 in New York City, the main concerns were very often not when do I get my next medication, but it was my dog is alone in the apartment, or could you please get someone to hold the iPhone so I can say for the last time, or, to my wife, I love you. And that was the most important part. So basically the question to all of you is how we can capture within that paradigm shift in medicine into the precision medicine, and within that second paradigm of science in the age of AI, the very important part of personomics. Thank you.
Ishani, why don't you take that?
I was going to nominate Michael.
Yeah, I think there are two things to hold in mind, right? Every human being is unique. And if we could have a choice between invent a molecule that cured all pancreatic cancer or make blood pressure control 5% better probably, we would save more lives by making blood pressure control. So some things like that you could run on a flow chart, we could have this enormous benefit for human health. And that the understanding of individuals, I said before, everyone, everywhere on their own terms, we're doing a lot of work in how do we give people the ability to have tools that understand their personal context and, also some of their physiology. And so it's really interesting to play with that, where you're like, oh, you get a thing of like, oh, you're at altitude, take it a little easy. Hey, remember that you got this thing scheduled, for your kid's birthday coming up. And I think we're 1 minute into a 90-minute match on how to do that.
So we have two questions about people and where does the patient come in. It brings me back to the Empathy Project, because if you go to empathyproject.com, which I would really urge you to do, not empathy.com, but empathyproject.com, we have 10 Hollywood-quality short films with the patient right at the center of it. If you go to that front page and you go down a little bit, you'll see a 7-minute animated movie called The Elephant in the Waiting Room. The Elephant in the Waiting Room is implicit bias. made by an Academy Award-winning, the person who did Zootopia, Phil Johnston. Delia Effron's a co-writer. The voice of Denise the Empathy Elephant is Whoopi Goldberg. And we're using it in curriculum all around the world. You can use this, for those of you who are interested, those and the other 9 movies, in your teaching for free, forever. We give it to you, and the only thing we ask is that you let us know how you're using it. But I think both of those questions, I'm thinking, yes, 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 that is the focus of what we do. And the patient, the first thing I thought it was, well, we're all for patients, but you're exactly right. We're all potential patients, but you really have to have them have a voice. And that's what I think a lot of us are focusing on with the Empathy Project. We have 18 seconds left, high, and now 14, and now 13. So I'm going to finish early and say thank you very much for being there. Good on you.